I'm the final speaker of the session. I know you're tired. There was this show by this politician. If you remember, just stand up and sit down. Thank you very much for listening to me. In the next room, 4 people are going to tell what I will try to summarize to you in 20 minutes only. This has been underlined many times. Non-approved, unapproved use is called off-label. It wasn't pointed out before, this is beyond the scope of this panel. In elderly, pregnant and children, the use of many medications is considered to be off-label. If you look at the literature, the most frequent off-label use happens in pediatrics because 90% of the drugs are off-label. For pediatric use, it's very common. This is not only limited to our country, it's seen all around the world. This is a very large study. You see that the percentage is very low. It should be even higher. 83% of gabapentin prescriptions are off-label and 81% of amitriptyline prescriptions are off-label. That's what we do. Everybody's doing it, me included. I don't think that anybody is not doing it, but there are certain questions that need to be discussed. Do you think that this matches with good medical practices, whether it's ethical, whether it's legal, and whether it's safe? Maybe at the end of my lecture I will try to answer these questions. As we have said before, the greatest challenge for us is the refractory or non-responders to treatment. You will see it for any conditions. Before calling a patient refractory, there are certain steps here that you need to go through. Whether you give the right dose, whether the duration of treatment was sufficient, and how the patient's adherence has been sufficient. Only then you can decide that the patient is refractory. We don't have a list of approved medications on the ministry webpage. You can access the FDA list for anxiety disorders. These are the FDA-approved antidepressants. The ones shown in blue are the ones that have been approved by the FDA. If you are using this drug for an indication not part of this list, this means that you are using this drug off-label. But what guides our daily practice is not only this list. We also take a look at the studies or trials if there's evidence from randomized controlled trials. And even if it's absent, if there are certain case reports, this may guide our way in our practice. I think these slides will be published on the Congress CD. You will get this chart from this list. As you can see from this chart, many indications for which we use this drug for example, one medication is not approved for depression. However, it's approved for other types of indications. These are the contradictions. Except for antidepressants, these are the old versions of DSM, buspirone and chloral hydrate, and we also have benzodiazepines that may be used for anxiety disorders. They have been approved by the FDA. The FDA approval is a bit different for these types of medications. For anxiety disorders, which is a very large spectrum of diseases, and for its symptoms of anxiety, it is indicated. In this case, you have a large spectrum of different indications, including sleep disorders and agitation, so you may prescribe them to any kind of anxiety patient. Off-label use of drugs may be discussed based on guidelines that are very, very modern, very recently. This is from the Canadian Society of Psychiatry. For panic disorders, evidence for it. We know that it's prescribed very frequently. However, if you look at the literature, even if you look at the dates, they are quite from the recent years. There are only 3 studies in the literature. And you should only use it for a short term in the beginning. If you look at it from the 4 weeks or 6 weeks, the addition of a benzodiazepine in terms of panic disorder, it doesn't benefit our patients. What happens if you have a refractory panic disorder? This is something which is seen very infrequently. if the patient also targets the agoraphobic deviation. Now, however, if we come across such a patient, what is left to us are the benzodiazepines, which have a very strong level of evidence. Then we have the small studies, uncontrolled studies like olanzapine. We have also the combinations SSRI with olanzapine or fluoxetine with tricyclic antidepressants. These are very old studies. Valproate may be combined with clonazepam. As you see, there are only limited number of studies. Are these the only drugs that are prescribed? I can see it from the prescriptions with my own eyes. You may use many different approaches. We use drugs of label in combination. At least we should review the negative studies. We should know them. Again, I would like to share with you the drugs that are not recommended by the guidelines, but they do not match because maybe they have been published in different years. For panic disorders, gabapentin, buspirone, bupropion, and propranolol do not work per se. Herbal remedies are not effective. The Canadian psychiatrist recommends to avoid the use of buspirone, trazodone, propranolol, and carbamazepine, but this is not the real life. The studies have been conducted in the United States, and we have our patients in Turkey too. Benzodiazepine are still used for a long term for panic disorders. If you look at the common anxiety disorders, 3 SSRIs, bupropion and buspirone, imiprin are the ones that have a label indication. All these drugs have a category of evidence. In addition, quetiapine will be licensed soon, and benzodiazepine and hydroxyzine have all a level of evidence, and we may use them. What happens in the real life? This is a study that comes from the United States. I would like to draw your attention to this part of the slide. In 4 out of 10 patients, benzodiazepine is prescribed for common anxiety disorder. As you can see, the frequency is quite high in these top 10 list of drugs. In terms of refractory anxiety disorders, we don't have many studies. There are only 2. In one, risperidone is added to SSRIs, and olanzapine was added on top of fluoxetine, and they have positive outcomes. You may use these combinations. Which drugs need to be avoided? Tiagabine, propranolol, kava. In the Western countries, they have the homeopathic formulations. Paroxetine, CR plus quetiapine have been shown to have no effect, and these drugs should be avoided, and the Canadians do not recommend propranolol. If you look at social anxiety disorders, we have the same picture. Everything's off label on the list. Here we have a different group of drugs, especially anticonvulsants like dopiramat, levetiracetam, or gabapentin or tiagabine are the augmentation drugs, add-on drugs. However, the following drugs are not recommended, and in this list, propranolol is even licensed. There is not much data to back it up, and it has received the approval without any data support. It may only use for a limited type of stage fear. Here we have less evidence, and the list of drugs is shorter too. Phenazepam is not available in Turkey. Maclobimide is initially it was launched for social anxiety, and we have only a limited number of refractory social anxiety disorders. Venlafaxine, escitalopram, SSRI in combination with buspirone may be beneficial in refractory social disorder patients. Which ones need to be avoided? Quetiapine, buspirone, beta blockers, pindol augmentations have not worked in these patients. Herbal remedies, imipramine and pergolate have been investigated in only one study, and other drugs in combination have not worked out. Okay, B is the most challenging disorder for us. And here we usually resort to something. Here the dose is important too, because if you have a refractory OKB, you have to exceed the upper limits, upper recommended dose by 25%. For example, sertraline has an upper limit of 200, 250 maybe tried clomiprin. If the upper limit is 300, you may also try 375 mgs. All the SSRIs may be used. Stelapram has no indications for any kind of an anxiety disorder, but we still know it is an effective anti-anxiety drug. Now, if you talk about refractory OKB, the strongest evidence level with B is clomipramine. Stelopram has evidence. Riluzole, there is a recent study to support it too, and then there are some experimental drugs. If you look at the combination augmentation, it has been investigated extensively. I have just given an abstract of what's available. Everyone has added some, that the classical antipsychotics, SSRIs, or in combination with clomipramine, or addition of lithium, L-tryptophan, or N-acetylcysteine, or an SSRI in combination with an NRI are the options that are available. And there is a clue about the age of label for adolescents. A clonazepam or risperidone may be added on top of an SSRI. These are the drugs that need to be avoided. You should keep in mind these are adrenergic, noradrenergic antidepressants are not beneficial for AKB. This is traditional classical information, and some combinations have not worked either. For post-traumatic stress disorders, we have a similar picture. Anticonvulsants are used very frequently. Almost all of the drugs in this class have been tried out. Addition of an antipsychotics has increased to number 2 along the ranking. Benzodiazepines alone are not effective. This is very important. Maybe you're gonna remember this part. An atypical antipsychotic as a monotherapy needs to be avoided, especially after traumas. I will just skip this. For combinations, addition of anticonvulsants or atypical antipsychotics or antidepressants, as well as other options, are listed on the slide. The more challenging a disorder is, the more diverse the additions are. What needs to be avoided? Bupropion, dopaminergic antidepressants, disciplamine, guanfacine, thiagabine, and valproate alone, alprazolam alone should not be used for this condition. And the recommendations of the two societies overlap with each other. This is the summary. If you look at the evidence levels, I have looked at my personal tendencies. My personal recommendations for panic disorders, we don't have much non-responders, but if we have a refractory case, we may use a benzodiazepine combination. For common anxiety disorders, there are some clues for antipsychotics. Maybe it's too early for their use. This is also true for social anxiety. For OKB, almost always requires a combinations, and for antipsychotics, a strong evidence is available, and which is reflected to our prescriptions still. When we have an OKB patients in the recent years, I don't leave the patient with an antipsychotic alone. I add something on top of it. For post-traumatic stress disorder, again, combinations, anticonvulsants may be used. Benzodiazepines are not recommended if there is no other comorbidity. For both OKB and post-traumatic stress disorder, this is how the patients feel well, and the studies in fact show, I'm talking about anxiety disorder patients without any comorbidity, not for alcohol consumption, not for borderline personality, Of course, in this cases, we have a high level of addiction, but even if it's used for a long time, there is no tolerance. You don't need to increase the dose. In this case, it's not bad and ugly as it seems, because these increments in this study, which includes 2,440 patients, was reported in only 1.44%. Even if it's risky, an off-label drug may be used in a rational way. However, benzodiazepine use is only maybe used in refractory patients and not as a first-line treatment. When all the options have failed, and if there is an intensive anxiety, you may consider the use of benzodiazepine. Very briefly, why do we use drugs off-label? For example, citalopram is an antidepressant. It has no indication for anxiety. And the drugs do not reflect the real world. Our patients are mixed type, they have comorbidities. And when the patients benefit from a drug, they don't want to discontinue it. And for certain types of anxiety disorders, this is not an official disorder. And we have, for example, we have separation anxiety. No drug trial has been conducted so far. What are we going to do in subthreshold anxieties? And we don't have any drugs available to us. The health authorities, I have recently published a directive in Turkey. They don't interfere with the use of the drugs. Is it legal? No, it's not illegal either. We are just caught in between. The drugs do not help us to achieve complete remission. We don't have any data on second and third line treatments, and the information is rapidly disseminated. For example, if my friend Albert tells me this drug is very effective for schizophrenia, in 2 to 3 weeks you have a very well outcome, I immediately start using it. We read also the journals, and we try to reach the database. Are they effective? The ones have some points to defend it. The advocates have to. So if the people use it and 80 or 90% of the people use it, then it must be considered to be indicated for this condition. And the studies show us that some of the drugs are properly prescribed and the patient benefit from it. Some drugs have some evidence generated from studies, and for some drugs some observations are made which may help them to come up with a prescription. The ones who are against off-label use tell us that this drug has been studied for on this condition only, and for other conditions we don't have any data, because the approved drugs are both effective as well as safe. In this case, why should we expose ourselves to high risk? It's not reimbursed. There are some side effects, more side effects. There are legal risks, and the physician's discretion, which is very subjective. I'm not talking about an experienced physician, but for the less experienced, this may be an issue. The answer to the first question I've asked at the beginning of this lecture, if you look in terms of a practice, yes. And the fact that it's illegal is only dependent on a patient who files a complaint against it. Right now we are able to do it. How should we do it? I've tried to emphasize it many times. The risk-benefit ratio needs to be well balanced. We need to reduce the anxiety, reduce the frequency of panic attacks. However, the patient should not gain weight like 20 kilos, and we shouldn't trigger metabolic syndrome in the patient. Of course, when you prescribe off-label drugs, you have to take some risks. And the dependency risk needs to be considered very seriously, and we should know all the combinations very well in order to mitigate the risks, which also means reducing the risks of the physician himself. You should have some sort of an hypothesis. When you prescribe a drug, you should just target something like decreasing the dopaminergic effect. You should have some sort of presumptions. You should use the guidelines. You should check the randomized controlled trial. You need to educate the patients on potential side effects, and if possible, you should obtain a written informed consent. if you are going to prescribe clozapine for a common anxiety disorder, you should get the informed consent, you should keep records, and you need to publish your data. Especially unexpected outcomes need to be reported. Kate, who is the inventor of lithium, is given as an example. He just established a hypothesis that saying that urea is harmful. And he injected urea to the guinea pigs and they died. Then he tried it on himself, the lithium, because it was effective on urea metabolism. Then he tried it on himself, and then he tried it on a patient. One of his first patients died, and then he published this. The patient was dead, it has a toxicity, you shouldn't use it. However, another group has established the serum levels and they have shown the effect and they have